Each life lost to suicide is concerning because we know it could be prevented. Approximately 8 adolescents are dying by suicide each day. That is concerning and heartbreaking.
We know from the data and from the states that we work with at the Children's Safety Network that suicidality for Black Americans peaks in early 20s and late 20s. Really focusing on those prevention efforts is very important.
Welcome to this Children's Safety Network conversation about trends in youth suicide in the United States. CSN is a project of Education Development Center and is funded by the U.S. Department of Health and Human Services through the Health Resources and Services Administration's Maternal and Child Health Bureau. I'm Jennifer Leonardo, Director of CSN. Many parents and health practitioners are concerned about the issue of suicide among young people. Suicide is the second leading cause of death for youth between the ages of 10 and 24, trailing only unintentional injuries. Compounding this is the stress, anxiety, and social isolation caused by the COVID-19 pandemic. One CDC study found that in 2021, 44% of high school students reported feeling persistently sad or hopeless during the past year. Effective mental health and suicide prevention programs are essential for this generation of young people. At CSN, we have been helping community and state-level practitioners better understand their data, needs, and opportunities around youth suicide prevention. In today's conversation, we will hear from two people who are working on this issue. Maria Katradis is a training and technical assistance specialist for CSN. Maria co-manages the Child Safety Learning Cooperative and is the content specialist for suicide and self-harm prevention and poisoning prevention. Dr. Bina Ali is a research scientist at the Pacific Institute for Research and Evaluation. Bina examines violence prevention, substance use prevention, and injury control. She is especially interested in understanding and addressing health disparities in minority populations. Now let's hear from Maria and Bina.
Hi, my name is Maria Katradis, and I'm the Suicide and Self-Harm Prevention Topic Lead for the Children's Safety Network.
Hi, my name is Bina Ali, and I'm a behavioral health researcher at the Pacific Institute for Research and Evaluation. I am also the director of the Children's Safety Network Economics and Data Analysis Resource Center.
So Bina, it's great to talk to you. Thank you so much for being here today. Could you tell me a little bit about yourself and what drew you to the field of suicide prevention?
Thank you for having me here today, Maria. I work in the areas of injury and violence prevention and substance use prevention. My interest in suicide research started when I was in grad school. I was interested in studying the underlying role of mental health and how it relates to different health outcomes. And as you know, there is a strong association between mental health problems and suicidal behavior. So that's when I started researching suicidal behaviors and also looking at literature as well as data from the National Surveillance System to try to understand what are the characteristics and underlying factors that are different by different populations and how we can use that information to prevent suicide in youth. So this is where my interest started, and I've continued to be in that field for a very long time. I've been in the mental health field for the past 15 years. And I also will add that my public health training has really given me that framework to try to understand not just the individual level factors, but also looking at the socio-ecological factors that contribute to suicidal behaviors and suicidal outcomes.
Great. Thank you so much for sharing that. And I think we have similar interests in looking at disparities and what contributes to suicidal behavior. So as the director of our EDARC Center, what could you tell us about the current scope of suicide among youth in the U.S.?
Great question. So in the Children's Safety Network, the focus for suicide prevention is for the age group 10 to 19. And suicide is the second leading cause of death in that age group, followed by motor vehicle traffic injuries. The most common mechanisms of suicide are firearm, suffocation, and poisoning. So this is where we tend to focus our work on.
How concerned should we be about what these data reveal?
So each life lost to suicide is concerning because we know it could be prevented. What data reveals is that approximately 8 adolescents are dying by suicide each day, and that is concerning and heartbreaking.
So are you seeing disparities or differences in who is at risk?
Absolutely. There are certain groups that experience disproportionately higher rates of suicide compared to other groups. Nationally, the suicide rate is 7 per 100,000 adolescents in the US, but the rates are much higher for male than female. For male adolescents, it's 10 per 100,000 versus 4 per 100,000 for female adolescents. Also, the rate is highest for American Indian Alaska Native adolescents, followed by white adolescents. Suicide rate in American Indian Alaska Native is about 3 times the rate that we see in white adolescents. So you can see that there are big differences in that data too. And of course, as we know from public health background, there are cultural and socio-ecological factors that contribute to the disparities that we see in the data. So there are concerns about the cultural disconnection, alienation, poverty, access to resources and services that oftentimes minority adolescents don't have available as easily. So those are all playing a role in the data that we are also looking at. Also in the data, we see that the suicide rate in Black adolescents have been increasing over the years from 3 per 100,000 in 2011 to 6 per 100,000 in 2021. That's almost twice as high.
So, Bina, are you concerned about underreporting of deaths by suicide or suicidal ideation for minority populations?
Suicide deaths are classified by medical examiners or coroners depending on the state's system. And we know from data that Black decedents have significantly higher odds of having deaths classified as undetermined intent compared to white decedents, and that suggests that there is some underreporting happening in Black decedents, and there is a higher likelihood of suicide misclassification in that minority group. Also, with the suicidal ideation, which is information that we can get from the high school youth, the data that we look at, the Youth Risk Behavior Surveillance System, that is self-reported data. And given that there is stigma around mental health and suicidal behaviors, there is a likelihood that it could be undercounted or youth just aren't reporting when they are feeling suicidal or engaging in suicidal behavior. So those are definitely some concerns that we have in the field when we look at this data. We have to know how these data are getting collected, how these data are getting coded, and also who is doing the reporting of the data.
So that's really interesting, Bina, because we know from the data and from the states that we work with at the Children's Safety Network that suicidality for Black Americans peaks in early 20s and late 20s for males and females. So really focusing on those prevention efforts is very important at a much younger age for the Black population.
Some of my colleagues and I have done some research to try to explore more robust data sets that are available that can give us a more comprehensive understanding of different factors that preceded before the suicide death. And what we have found is that there are differences in racial ethnic groups in terms of different factors that they experience or different circumstances that they experience right before the suicide. What we have seen is that all minority decedents exhibit a lower likelihood of documented mental health problem and mental illness treatment compared to the white decedents in adolescence. And our understanding of differential circumstances and how to mitigate those, I think is still growing because we can look at this information in 2 different ways. First is that we know racial ethnic groups, they're less likely to receive services for mental health. Underutilization of services often relates to social cultural factors such as social and psychological stigma around mental illnesses and help-seeking behavior, limited knowledge and access to those resources, and also structural barriers related to availability and quality of care that minority individuals are able to access. And on the other side, we also know in minority groups, adolescents who adhere to traditional norms are exhibiting stronger ties to their families and communities and cultures, and that serves as a protective factor. So we're still looking at the risk and protective factors at the same time as we're trying to understand what are the differential risk factors for minority adolescents in terms of suicide prevention.
So at CSN, we're trying to help state health departments address those different factors that are contributing to these disparities. Tell us a little bit more about the recent data that you've seen, Bina. Could you tell us a little bit more about how these recent data compare to numbers from 5 or 10 or even 20 years ago?
One issue with data that we have is that at the national level, we're still a few years behind. So the latest mortality or fatality data that we're currently looking at is from 2021. So we can look at the past 5 years of data that we have. And so when we look at from 2017 to 2021, that data is showing us that there have been a slight decrease in suicide deaths in youth, and that decrease is about 2% on average per year. However, when we look at this trend statistically, it's not significant. So that is something we have to be mindful of, that just because we see a trend downward does not mean that it's statistically significant. More data has to become available for us to make that assessment. We still have data from previous years that we can look at. Over the past 10 years of data that we have, so between 2012 and 2021, we have seen a 4% increase in suicide on average per year in adolescents, and that upward trend is statistically significant. We see the same data for the past 20 years. Between 2002 and 2011, there has been a 2% increase in suicide deaths in youth, and again, that is statistically significant. We have another data set that we have been looking at for suicide prevention work that we do. And that data set gives us information on youth attempting suicide, youth making suicide plans, and also actually attempting suicide. So not just considering suicide, but actually attempting suicide. And what that data has shown us is that over the past 5 years of data that we have available on that, from 2017 to 2021, there has been a worsening trend in number of youth who are having suicidal thoughts and behaviors. And we see the same data for the past 10 years. So that data, unfortunately, is telling us that the problem is worsening, but there is hope because we know suicide is preventable.
So what can youth health practitioners at the state level take away from this data?
So before looking at data, the first thing I would like to mention is that suicide is preventable. So that is something we have to keep in mind as we're looking at data that is sometimes daunting, because when we look at this data, each death that we see on there, this is an actual life lost. So it's very hard for us to look at this data without having the big picture in mind, that this is something that can be prevented and we can put this prevention effort in place to prevent future death. So that's something I think is very important for us to keep in mind in this field. What the data is telling us is that the problem is worsening over time when we look at the statistically significant trend over time. And unfortunately, there is a lot of work for us to do in this area still. However, with the robust data sets that we now have available, we are getting a comprehensive understanding of the factors at individual level, relationship level, community level, and societal level to address the problem. And data is telling us that there are differences by subgroups of populations, so the intervention that we are implementing needs to be tailored for specific subpopulations that are at risk for suicide.
At CSN, we've been hearing a lot about the need to address suicide at younger and younger ages. And over the past 7 years of working with our learning collaboratives, we've been hearing that waiting until middle school to address suicide prevention is too late. Educators and health professionals have to start even earlier, and that's a change from the past.
And that is an interesting point that we've been talking about in the field as a whole, too. When we analyze data, we are looking at 10 to 19 age group for the CSN. However, restricting data to persons ages 10 and older is a common practice in the suicide prevention field. And the reason why we do that is because determining suicide intent is very difficult in younger population. However, as you mentioned, there have been practice-based research and articles that have been written that talk just about that there are suicide deaths being identified in younger population. And there is some research that shows suicide in children as young as 5 years old. So clearly that's a concern there.
Yeah, and we've definitely heard this from the states that we work with on the suicide and self-harm prevention topic team of our Child Safety Learning Collaborative. Anecdotally, we hear about these deaths by suicide in and younger children, but it seems that the data is suppressed because of the low numbers.
Yeah, oftentimes that's what we have to do. Any number that's less than 10, we have to suppress that because it's considered unreliable data.
So to address this issue of pediatric suicides, one of our states, Kentucky, is actually offering QPR, which is question, persuade, refer, to all pediatric hospital staff. And now they're beginning to spread to all staff across the healthcare system so that anyone who sees or interacts with patients has training on suicide prevention. So as the director of the Children's Safety Network Economics and Data Analysis Research Center, you use data and research to support state efforts to prevent child injury and death, including by suicide. What are 3 things that state and community-based practitioners can do to improve suicide prevention programming and services for young people at risk?
All right, so 3 things. One, the most important, I would say, would be to focus on restricting access to lethal means. So suicide acts are often impulsive. The interval between deciding to act and attempting suicide can be as brief as 5 to 10 minutes. Also, people tend not to substitute a different means when a highly lethal method is unavailable. So limiting access to lethal mean is a proven way to prevent suicide. Measures such as disposing of leftover drugs, keeping track of the family's medications, also storing firearms in lockboxes, keeping them unloaded, ammunition stored separately from the firearm are all proven effective approaches to preventing suicide. And training and providing support to clinicians, hotline workers, and other practitioners around mechanisms of suicide can also be very helpful in screening and assessing the risk of suicide and preventing it before it happens.
So that's interesting that you mentioned access to lethal means. One of the states that we had in our previous iteration of the Child Safety Learning Collaborative, Louisiana, is addressing this issue with their Be Smart campaign, where they're championing firearm safety and safe storage as a means to preventing child and adolescent suicides.
Another thing that I would say is also important is suicide prevention efforts need to be comprehensive. So this includes enhancing social support, access to health services, development of life skills, and social emotional learning, all effective in reducing suicide in youth. Education and training on cultural sensitivity is something that is also very important, especially for healthcare providers when they're working with youth who are minority or belong to a high-risk population such as LGBTQ. Reducing stigma around help-seeking behavior, that is also something that is very important and part of the comprehensive efforts that we need to do to address suicide in adolescents. And this includes using health equity lens for implementation efforts too. When we talk about comprehensive suicide prevention, it requires us not just to work with the practitioners, but it includes working with public health workers, epidemiologists, psychiatrists, physicians, toxicologists, medical examiners, coroners, policymakers even, and other healthcare professionals who are collaborating and working together to understand what is going on in their community, using the local context and understanding of their populations, and then using that to inform their behaviors and implement prevention approaches.
We see this programming in Tennessee, where they have spread QPR, again, question, persuade, refer, across the state for all youth impactors. So they're really looking at everyone who has access to children and adolescents in a way to prevent deaths by suicide. Additionally, they were one of the first states in our learning collaboratives to use their data for surveillance purposes and also to create alert systems that go out to local counties and to school districts to indicate when there's been a death by suicide, suicidal ideation, or an attempt. And that has really helped them develop this comprehensive approach towards suicide prevention in this age group.
And I'll also add that focusing on quality improvement approaches to implement evidence-based practices is a strength. So as our audience know, there are evidence-based practices. As you're mentioning, the QPR is an evidence-based approach, and many of the states are using that, which is great. So there are evidence-based practices available for suicide prevention. What we are also seeing in practice is that evidence-based practices cannot be copied and pasted into different settings. They have to be tailored and adapted for the local context and applied in such a way. So using the quality improvement approaches such as testing the small test of change to see what is working well, what needs to be tweaked a bit, making sure that the essential elements that keep the evidence-based practices strong enough are still intact is a really good way to implement those practices in local settings, see how that goes, and then spread it to more larger settings. So that is something that we have learned has been very helpful for different states who are using quality improvement to then implement and spread evidence-based practices.
I think those are very helpful recommendations, Bina, and I really want to thank you so much for spending the time with us today and sharing your expertise on this topic.
Thank you very much, Maria. It was great to be here.
Thanks for listening to this conversation from Children's Safety Network. If you are interested in learning more about how CSN is advancing child safety across the United States, visit our website, www.childrenssafetynetwork.org.